Good afternoon, and welcome to this session titled Stigma, Breaking the Silences, Dealing with Stigma and Exclusion for People Living with HIV and HIV/AIDS Affected Populations. My name is Maria Ekstrand, and I'm from the University of California, San Francisco, and it's my pleasure to introduce my co-chair, Dr. Shalini Bharat from the Tata Institute for Social Sciences in Mumbai, India.
Hello, everybody.
Yeah. So, do you want to introduce the first person?
Okay. So we are here to listen to 5 speakers on the topic of stigma. Without wasting much time, let me introduce to you the first speaker, Mr. Zagazia Bezadi. He obtained his MSc degree in demography from Addis Ababa University in 2003. He worked in various organizations, including the World Food Program as a research and M&E officer. He worked with UNAIDS and M&E advisor, and recently worked as principal investigator for a national level study on stigma. Mr. Zagazia Bezadi.
That's the wrong presentation. There you go.
Ms. Jain is a PhD candidate at Johns Hopkins University and is currently an independent consultant. Previously, Ms. Jain worked at the International Center for Research on Women and Gender Health on a variety of sexual and reproductive health research projects, including HIV and stigma. Over to you, Ms. Jain.
Thank you, Shalini. It's a great pleasure and honor to be here today and to share the results of this study. I would like to take a moment to first explain the organization's roles on the project. The Population Community and Development Association implemented the Positive Partnership Project Phase 2. They did this with support from PAC Thailand and with funding from PEPFAR. The International Center for Research on Women provided technical assistance in the analysis of the community baseline and inline data sets, and I was hired as an analysis expert to consult with ICRW. So this is the outline of my presentation today. I'm going to go ahead and jump right into the project interventions. So the main goal of the Positive Partnership Project was to provide low-interest loans to a buddy pair. That's an HIV positive and an HIV negative individual. This was done to economically empower people living with HIV and improve their quality of lives. There was also a focus to reduce HIV stigma and discrimination within the communities where the loan recipients lived. For the overall evaluation study, data were collected among multiple groups, including people living with HIV who received loans, their buddies, and community members. From the overall evaluation, we know that receiving loans has improved the self-efficacy and the self-esteem of people living with HIV. But the focus of this presentation today is only on the community data set and the specific HIV interventions at the community level. So 2 project models were implemented and developed. The first was the PPP clubs, and these were formed organically by support groups of people living with HIV. The second model was village development banks that were formed mostly by community members and community leaders. Both of these entities were responsible for dispersing loans and conducting HIV awareness activities within their communities. 4 HIV stigma reduction activities were implemented within the community. The first activity was monthly meetings on banking days. These days included both financial and HIV education activities. So for example, one village development bank reported inviting a person living with HIV who was open about their status to speak about their experiences with HIV stigma. The second activity was HIV campaigns, and these were held continuously throughout the project intervention period. An example of this was house-to-house visits to provide residents with HIV knowledge and raise their awareness about HIV stigma. The third intervention was 3 IEC materials, and those are posters, banking slips, and radio dramas. Fun fairs was the final intervention, and these are basically education and entertainment events that focus on disseminating HIV information. So 11 PPP clubs and 12 village development banks were formed. The project was implemented from April 2008 to September 2010. So as I mentioned earlier, the community data set was just one piece of the overall evaluation study. The community study consisted of a panel of 11 communities. 2 cross-sectional surveys were implemented, one at baseline and one at endline. A sampling frame of households was developed in each community, and households were selected using systematic random sampling. All individuals 15 years and older were interviewed within each of the households. Previously validated measures and new items to the Thai context were used in the surveys. The measures captured 2 drivers of stigma. The first driver is fear of acquiring HIV through everyday contact with a person living with HIV. And the second driver is related to values that link people living with HIV to behaviors that are considered improper and immoral. For the multivariate analysis, we developed scales using principal component factor analysis to identify unidimensional constructs at baseline. We then confirmed these scales the factors at endline. We tested the reliability and the validity of each scale, and then predicted regression scores. We then standardized the scales to have a mean of 50, a standard deviation of 10, and the scales ranged from 0 to 100, where higher levels or higher scores indicated more stigma. So respondent characteristics were similar at both baseline and endline. For example, as you can see here, there is no significant difference in age. Correct knowledge of HIV transmission, prevention, care, and treatment increased from baseline to endline. Across 8 questions, correct knowledge increased significantly. Across these 8 questions, correct knowledge increased significantly on the first 5 that are presented here in the graph. While correct HIV knowledge improved, at endline it remained relatively low. Fear of HIV transmission through everyday contact with HIV-positive individuals reduced. 4 of 6 items reduced significantly. Agreement with statements about shame reduced from baseline to endline. So in this graph, we can see exposure to the interventions, and exposure to 3 of the interventions was relatively low, and that's the banking day meetings, the campaign, and the fun fair. In this exposure variable, we combined 4 interventions, the banking day meetings, the fun fairs, and the HIV campaigns, and an exposure to at least 1 IEC material. Exposure to at least 1 IEC was formed by combining posters, radio dramas, and banking slips. We found that 87% of respondents reported exposure to at least 1 IEC material. And this graph shows that the majority of respondents were exposed to only 1 intervention. So we first conducted bivariate analysis and then ran our multivariate models. This model shows the beta coefficients, 95% confidence intervals, and the p-values of 3 main predictors on fear-driven stigma. This model is adjusted for respondent characteristics, media exposure to HIV messaging, and baseline community average of fear. Respondents who reported that they personally knew someone living with HIV scored 2.6 points lower on the fear scale. Higher HIV/AIDS knowledge at endline also predicted lower levels of fear, where respondents who answered 4 to 9 questions correctly scored 4.8 points lower. And in terms of the intervention exposure, the effect of participating in 3 interventions, specifically the campaign, fun fair, and IEC, reduced fear on the scale by 3.8 points when compared to no intervention exposure or exposure to exactly 1. This model presents the adjusted linear regression of the same 3 key predictors on the shame scale. As with fear, respondents with high levels of correct HIV knowledge scored 3.8 points lower on the shame scale. Also, respondents who reported exposure to the campaign, funfair, and IEC materials scored 4.3 points lower on the shame scale. And personally, knowing someone living with HIV was borderline significant with a p-value of 0.05. So in summary, we found that with relatively minimal community-level HIV interventions, we began to see shifts in correct HIV knowledge, fear of HIV transmission, and shame associated with having HIV. However, here we are 30 years into the epidemic, and low levels of HIV knowledge continue to persist in these communities. From our multivariate linear regression analysis, we found that respondents with a greater correct HIV knowledge scored lower on both the fear and the shame scales. We also found that personally knowing someone living with HIV was associated with lower levels of fear, but not with shame. Finally, our results suggest that a combination of interventions helped in beginning the shift in community-level fear and shame, and specifically those are the HIV campaigns, fun fairs, and IEC materials. So even though the focus of this project was to provide loans to people living with HIV, there are some important conclusions that we can draw about HIV stigma. The first conclusion, which is also a lesson learned, is that the project involved affected populations in every step of the design, from developing the intervention models to implementing the HIV community level activities. In spite of some of our study limitations, our findings are in line with previous research. Our study reconfirms the importance of tackling HIV stigma in multiple ways. For example, the project used IEC materials and also developed platforms for interactions between community members and people living with HIV. Our results suggest increasing correct HIV knowledge is an important first step in reducing HIV stigma. This research is especially important given Thailand's new HIV/AIDS strategy, in which one of its goals is to reduce HIV stigma by half by 2016. These findings provide a good starting point for policymakers to consider in achieving this goal. I would like to acknowledge the following individuals for their contributions in the study and presentation, and the Department of Population, Family, Reproductive Health, and the Bill and Melinda Gates Institute, both at Johns Hopkins, for supporting my participation at this conference. Thank you.
Thank you, Aruna. Aparna, we would like to now open the floor for some questions for just 5 minutes, so please stay on here. Any questions specific to this presentation? Okay.
Question.
Mic 4.
Were there any faith groups that were involved in this study?
Were there any faith-based groups involved in the study? One of my co-authors is in the audience who's very involved with the project. Prim, I believe that there weren't any faith-based organizations, but I'd like her to please answer it. Mic 3.
There were not any faith-based groups, but the fun fair sometimes were organized in a temple or a Christian church.
Any other questions? Okay, thank you very much.
Thank you, Aparna.
Good job. We now have
Go ahead.
the second presenter, Carmen Logie. Carmen Logie is a Canadian Institutes of Health Research postdoctoral fellow at the University of Toronto. Her research focuses on health equity and human rights, with particular attention to associations between stigma and health outcomes among the LGBTQ population. Carmen, your presentation.
Hello everybody, thank you for coming today. I'm going to be talking about racism, sexism, HIV-related stigma, and associations with quality of life among HIV-positive African, Caribbean, and Black women in Toronto, Canada. I'd like to acknowledge my co-authors, Lana James, Wangari Thoreau, and Mona Lutfi. So in Canada, African, Caribbean, and Black women are 7-fold overrepresented in HIV new infections in comparison with their white counterparts. And qualitative research suggests that stigma and discrimination based on race and ethnicity, gender, and HIV serostatus contribute to both increased vulnerability to HIV infection and reduced access to care once people are HIV positive. And I'm sure most people already understand what HIV-related stigma is, but I just want to provide you the definition I'm working from, which is processes of devaluing, labeling, and stereotyping that result in loss of status, unjust and unfair treatment, and social isolation of people living with and associated with HIV. And there's multiple forms of HIV-related stigma that I'll be talking about today. So enacted includes acts of discrimination, internalized as negative beliefs, views, and feelings about HIV, AIDS, and oneself, and perceived, which is awareness of negative social attitudes and the negative social identity associated with people living with HIV. So we also looked at racism and racial discrimination, which refer to inequitable and oppressive systems founded on ethno-racial differences, including beliefs, attitudes, exclusion, and these are also manifested across institutional domains such as unequal access to material conditions and opportunities, so personally mediated, so acts of prejudice and discrimination, and internalized racism. And sexism and gender discrimination are oppressive and inequitable systems based on gender bias and attitudes, treatment values, and also manifest in violence, discrimination, and cross-institutional policies. So we addressed 2 gaps in the literature. The harmful impacts of HIV-related stigma, sexism, and racism have been widely documented across diverse samples. However, we found no studies that looked at these 3 forms of stigma and discrimination concurrently. So that was something that we looked at in order to fill that gap. And also the roles of social support and resilient coping in moderating or mediating the impact of these forms of discrimination on well-being are not well understood. So we use an intersectional theoretical approach which looks at the interdependent relationship between social identities, such as ethnicity, and social inequities, such as racism. So our objectives were twofold. We examined the associations between racial discrimination, gender discrimination, HIV-related stigma, and quality of life among African, Caribbean, and Black women living with HIV in Ontario, Canada. And we looked at social support and resilient coping and their role as moderators and mediators of the association between these forms of stigma, discrimination, and quality of life. So this is a multi-method approach. The qualitative phase, which is phase 1, involved 15 focus groups, diverse women living with HIV across Ontario. 104 women participated. And we published this study, which was presented in Vienna actually, in PLOS Medicine in November. And we came up with this conceptual model which we tested in this phase 2 that I'm talking about today, that looked at racism, HIV-related stigma, and sexism across micro, meso, and macro levels. And also we looked at resilience and social support as coping strategies that women living with HIV enact to deal with these forms of stigma and discrimination. So what I'm talking about today is phase 2. We conducted a cross-sectional survey with HIV-positive African, Caribbean, and Black women. 166 women participated. We used a community-based approach. We used measures with established reliability and validity, the HIV-related stigma scale revised based on Berger scale, which looked at personalized, which is similar to enacted stigma, disclosure, negative self-image, which is similar to internalized stigma, and public attitudes, which corresponds to perceived stigma. We used the everyday discrimination scale to look at racial discrimination, and we modified that to look at gender discrimination, the WHO quality of life HIV brief scale, that had 6 dimensions of quality of life: physical health, psychological health, independence, social relationships, environment, and spirituality. We used the MOS social support scale and the brief resilient coping scale. So we conducted bivariate correlations and hierarchical block regression analyses to look at the associations between the independent variables, so HIV-related stigma subtypes, racial discrimination, gender discrimination, the moderator and mediators, social support, and resilient coping, and the dependent variable, which is quality of life. So moderation analyses test if the social support and resilient coping changes the strength or the direction of the relationship between stigma, discrimination, and quality of life, whereas the mediation analysis assessed if the independent variables were associated with significant changes in the mediators, so social support and resilient coping, which would then in turn impact quality of life. So a brief look at our sample characteristics. The mean age was 40.7 years. Mean length of time in Canada was 8.9 years. About 90% of participants were born outside of Canada, across about 50 different countries. Education was a very diverse group of educated people. So some people, 28% less than high school, 26% at high school, 28% had college diploma, and 16% had a university degree. Just want to give you a glimpse of our frequencies. So almost 30% of participants reported they experienced racism on a frequent or everyday basis. 22%, so over 1/5 of participants experienced sexism on an everyday or very frequent basis. And participants reported experiencing most types of the HIV-related stigma we measured. So 84.4% disclosure-related stigma, over half personalized stigma, 40% public attitudes, and over 1/4 negative self-image. So I'm not going to talk about all of the bivariate correlations, but what's important to note is that HIV-related stigma, gender discrimination, and racial discrimination were positively correlated with one another, and with lower levels of quality of life, social support, and resilient coping. So in the first regression analysis, we looked at what were the correlates of overall quality of life. In the block 1, we put the different forms of stigma and discrimination, and we see that those variables accounted for 20% of the variance in quality of life scores, but actually the only significant correlates in this block were HIV-related personalized stigma and HIV-related negative self-image. In the second block, we added resilient coping and the different forms of social support, and we found informational support was the only significant correlate, and that model accounted for 30% of the variance in quality of life. In our moderation analyses, we did not find that social support or resilient coping moderated the impacts of the independent variables on quality of life, either the overall quality of life or the quality of life domains. We did find, however, that social support partially mediated the relationship between HIV-related stigma and quality of life. But wait a second, it's not so simple. We get a very different picture when we look at the different quality of life domains. And you can see that every single domain of quality of life has different correlates associated with it. So HIV-related personalized stigma is associated with the psychological quality of life, environmental aspects of quality of life. The HIV-related negative self-image is associated with psychological, independence, social relationships, spirituality. Racial discrimination is associated with social relationships and environments. And the resilient coping is associated with psychological independence and social relationships. So it's a very complex picture here. I color-coded it just to try to show how every single domain has different correlates. And then a similar situation happened when I looked at the mediators. So social support and resilient coping mediated the impact of HIV-related stigma on psychological quality of life, independence, and social relationships. And social support was a partial mediator of the association between HIV-related stigma and environmental quality of life. So to summarize that, there's a really complex relationship between the different forms and types of stigma and the different quality of life domains. So HIV-related stigma was associated with most quality of life domains, 4 out of 6. Resilient coping is associated with half, and personalized HIV-related stigma and racial discrimination with 1/3 of the domains of quality of life. And resilient coping and social support were also associated with 3 out of 6 and 2 out of 6 domains. So what does this all mean? So the associations I talked about, the bivariate correlations between racial discrimination, gender discrimination, and HIV-related stigma, highlight the importance of using an intersectional approach. We looked at the different forms of stigma and discrimination based on different aspects of someone's identity. HIV-related stigma was associated with lower quality of life, and social support and resilient coping did mediate the relationship between stigma and quality of life across several domains. And racial discrimination was also associated with lower quality of life in the domains of social relationship and the environment. So you might ask, why are racial and gender discrimination correlated with overall quality of life in bivariate analyses, but not in the regression analyses? You might remember I mentioned we didn't find any studies that have ever looked at these 3 variables at the same time and their associations, and particularly not with quality of life. So our results do suggest that HIV-related stigma might play a larger role in predicting overall quality of life among African, Caribbean, and Black women living with HIV in Ontario. Why? We don't really know. I have some hypotheses. There may be less within-group variability regarding racial and gender discrimination among ACB women than experiences living with HIV. With regards to living with HIV, there could be different contexts and length of diagnoses, different beliefs and attitudes regarding HIV, from growing up to current situation, different levels of support and disclosure. Racial discrimination was associated with certain quality of life domains, but not the overall quality of life score. This really highlights for us that we need to look at the different domains of quality of life. And we only measured discrimination, so enacted stigma, rather than the other aspects of stigma associated with gender and race, such as internalized stigma. So this is a limitation of the study, and perhaps if we had used more complex racial and gender discrimination tools, we would have found that there was other aspects of racism and gender discrimination that would have been correlated with quality of life. And sexist and racist stereotypes have permeated HIV discourse since the epidemic's beginning. So it may be hard to disentangle the separate effects of racial discrimination, gender discrimination, and HIV-related stigma. So the implications, multi-level interventions. We could have counseling that challenges the negative self-image associated with HIV and associated with lower quality of life. Strategies to build this resilient coping skills which can mediate the relationship between stigma and quality of life. Meso-level interventions, social support groups and initiatives, campaigns, for example, what was discussed by the previous presenter, community-based campaigns, mass media campaigns to challenge stigmatizing social norms and values, not just associated with HIV, but also racism and sexism within society and within HIV discourse and HIV stigma. And structural interventions to train healthcare providers and aid service organizations to address racial and gender discrimination and HIV-related stigma, and also to really try to promote programs that will promote quality of life. And researchers, we should integrate intersectional approaches in research. So not just look at HIV-related stigma, but look at stigma discrimination based on other aspects of people's identities, and also to look at the complexity of quality of life and the complexity of the different forms of stigma. I just want to acknowledge Canadian Institutes of Health Research for funding the operating grant. The PIs were my co-authors on this study, Dr. Mona Lutfi and Wangari Thoreau, and my postdoctoral fellowship that supported me during the analysis of this research, and the participants, peer research assistants, community advisory board, and participating agencies. Thank you.
Thank you, Carmen, for your presentation. We will now take questions on this presentation. Mic number 3.
Yes, I was just wondering, to what extent do you think it's appropriate and relevant for healthcare providers and counselors to use as an intervention their self-disclosure of their HIV status and trying to reduce stigma with those who they're working with who are dealing with HIV?
That's an interesting question. I think that disclosure, I think it depends on the context of the relationship between either the ASO worker or the healthcare provider. A lot of studies have shown that disclosure of a similar marginalized status does promote rapport between either a provider and a patient or a provider and a client. So I mean, I think that is a potential way to build rapport between, but I think as a social worker, I also know that there's issues sometimes with boundaries as well, and with sometimes assumptions if you both share the same experience, that is similar rather than different. So I think that's a very complex area that we haven't really looked at enough when it comes to sharing HIV status between, say, doctors and patients. I haven't seen a lot of literature on that, but I think it's really important to look at that. I've seen more of it with regards to, say, peer workers. So all of the research assistants either identified as an African Caribbean woman or an African Caribbean woman living with HIV, which I definitely think helped to build rapport for these women to even fill out the survey, which was a very personal questions. I don't think we would have had the same level of honesty in this project without engaging people who who shared some sort of similar experiences. So.
Thank you.
Yeah, again the mic 3, and then we'll go over to mic 4, please.
Hi, that was a really great study. It was really nice to see the way you tried to disentangle some of these multiply stigmatized identities. I was wondering if you could tell me a little more about the brief coping or the resilient coping and what that measure was like.
Well, this scale is very useful because it has only 4 items. And most times when I've seen research on coping and people living with HIV, it's more on maladaptive coping strategies rather than on, say, resilience and resilient coping. So the questions included things like, I believe I can learn from difficult things that happen to me. I believe that, if difficult things happen, I can make it through them. So it was sort of optimism as well as resilience. And I've validated it in salvage reliability among different populations around the world as well. So I would be willing to, if you're interested, I can send you the scale. So, okay.
Microphone 4.
Hi, I'd also like to thank you for your presentation. I'm wondering 2 things. First, the intersectionality theory that you have. Doesn't that also imply interaction terms within your model? And did you test that? Were you able to test that? The second thing was enacted stigma and discrimination may be different than the stressfulness of that stigma. And was that, I don't know if I missed that. Did you measure also how stressful the situations were?
No, we didn't measure the stress of the situation, but what we're doing right now is a national study that's looking at racism, and we're looking at the frequency of experiencing racist events and the stress. So this was, a pretty small sample size. So with all of the variables I included, I didn't test interaction terms, but I tested moderation and mediation. So there is a possibility that we didn't have sufficient power to detect if we did have a moderation effect. But yeah, I think, what this really highlighted is the need to go more in depth into our analysis of racism and sexism and use more complex scales that there's many, many racism measures out. So to really look and see what makes sense for this population, which was actually a challenge because most racism scales have been developed in the United States, not in Canada. And there's differences. We spent about 6 months trying to choose the scale that would be the most appropriate, and we pilot tested it to see if it had some validity for the population we're working with.
Thank you.
So.
I'm a nurse practitioner at San Francisco General Hospital in the AIDS clinic, and I'm wondering if you have suggestions for medical providers about how we can work with our patients in a medical appointment who are dealing with these kinds of discrimination.
Well, I think there's something about open dialogue about another result that came out of this that I don't present today, but is 2/3 of the participants in this study met the criteria for moderate to severe depression. And so I think that's very clear. Our healthcare providers, when they're working with people living with HIV and women living with HIV, particularly marginalized women like African, Caribbean, and Black women, to maybe screen for depression, to talk to people about the stigma that they're experiencing, to make sure that they are aware of the community groups that can work with women living with HIV, so they can refer them to support groups, possibly to counseling if that's what people want, to other community-based agencies. So I think having an open dialogue about stigma and discrimination, which I'm not sure how often that happens between healthcare providers and patients, and also the doctor being aware, or the healthcare provider being aware of what services are out there. So that could take, maybe connecting with different agencies and doing a little bit of research. And then
Right.
Third, to look at depression.
I think I shy away from asking a direct question like, are you dealing with stigma? But it sounds like you're suggesting to go ahead and do that.
Sorry, I can't hear you very well.
I think that I shy away from asking a direct question like, are you dealing with stigma? But it sounds like you're suggesting to go ahead and do that.
Well, I think it also depends on the comfort level and the knowledge of the healthcare provider around what is stigma and what is discrimination. But I think, you know, doing even a brief mental health assessment, talking with people, building rapport about their life, I think that that might be a step towards women even talking about these experiences. So.
Thank you.
Okay, the last question at mic 4.
I understand it was a relatively small study, but I wonder if you could either conclude or maybe it just suggests that negative self-image is the most important factor in stigma.
Well, in this analysis, it was associated with the most quality of life domains. So I would say, for this analysis, negative self-image. I'm hesitant to say that because then that leaves the impetus on the person to change their self-image rather than on us to create a more equitable and non-stigmatizing society. So I'm like, yes, there is a lot of associations between negative self-image and quality of life, but I think that's really indicative of social norms that are stigmatizing. So,
to me, it's also a challenge to the faith community because a lot of negative self-image is associated with judgmental faith attitudes. So to me, I take your study as a challenge to faith communities to really work on this negative self-image thing.
okay.
Okay, thank you, Carmen. And I would now invite Maria to introduce the remaining speakers.
Thank you, Shalini. It is my pleasure to introduce Gabriela Gomez, who is a postdoctoral fellow at the Amsterdam Institute for Global Health and Development. She obtained her PhD in infectious disease epidemiology and is currently working on operational research projects, including the assessment of cost-effectiveness of service expansions for HIV treatment and prevention for key populations in Southern Africa. Welcome.
Thank you. Thank you very much and good afternoon. And it is a pleasure for me and an honor to be here to have this opportunity to share with you some of the results of this analysis. We look at the stigma and serostatus disclosure within partnership in 4 African countries using a mixed method approach. As you know, disclosure of one serostatus to partners is a difficult step, and disclosure is also reported to be low in general and in sub-Saharan Africa also, in particular. However, the knowledge of each other's serostatus is a prerequisite to fully access prevention and care for serodiscordant couples. The rates of disclosure vary both between and within countries, and in particular, it varies by ethnicity, gender, and age, with a significant proportion of HIV-positive patients waiting over a year to disclose to their partners. Fear of enacted stigma, which includes experiences of violence, abandonment, and divorce, also prevent disclosure to partners. In general, partner disclosure requires trust. Trust that the intimate other will provide care and understanding while refraining to contribute to the enacted stigma. So for this study, our aim was to explore the determinants of disclosure to partners in 4 countries in sub-Saharan Africa, integrating data from the qualitative and the quantitative arms of the match study to better understand this process. So the match study was a survey among clients from healthcare facilities in the capital region and 1 rural province or district in each country. The countries were Uganda, Kenya, Burkina Faso, and Malawi. It included health facilities, including integrated facilities such as hospitals and primary care facilities where VCT was provided, and also antenatal clinics and other facilities offering care to pregnant women, and standalone facilities for VCT, but also for other HIV prevention services. A total of 3,659 participants completed the questionnaires. We also undertook 102 in-depth interviews with key informants and 20 focus groups discussions with support group members. For the quantitative analysis, we selected from the 3,659 participants, those that had an HIV test that was performed after 2007, that knew their HIV serostatus to be positive for more than a week, and that reported to be married or cohabiting. And at the end, a total of 280 participants were included in the analysis. Our analysis was a hypothesis-driven analysis. We looked at the narrative of the HIV positive participants from the open-ended questions in the questionnaires, and also in their answers to the in-depth interviews and the focus group discussions to define the determinants that we were then going to include in the quantitative analysis. Those determinants were at an individual level were gender, age, education, the presence of symptoms requiring HIV test, or treatment at the most recent test. We also look at membership to support groups and stigma. Stigma was in particular defined as two variables: self-stigma, which included inner feelings of worthlessness and or guilt, and enacted stigma, with reflected experiences of verbal abuse and ridicule, physical assault, ostracism from social life, abandonment by spouses, partners, or the families, disinheritance, job loss, and denial of health care due to being HIV positive. We built bivariable and multivariable logistic regression models to look at the interaction between these. And the main outcome was disclosure to partners. As you can see, all participants that were included actually reported disclosing their serostatus to someone, of which 60% reported doing so to partners. The prevalence of disclosure varied across countries. While it was very high in Kenya, it was quite low in Malawi. Participants were more likely to report self-stigma in Burkina Faso. While they were less likely to report self-stigma in Malawi, it was in this country that they were most likely to report enacted stigma. In fact, it was mainly individual enacted stigma. Community level stigma was actually quite low, and it was reported in approximately the same levels across the 4 countries. Here we present the results of our logistic regression models. In the first column of the table are the determinants of, are the results of the unadjusted odds ratios, where you can see that most of the determinants were actually found to be associated with disclosure, except for self-stigma. In the second, so basically men were more likely to disclose, as were those with higher education level or older age. And members of support groups, those participants reporting enacted stigma, and those presented with symptoms were less likely to report disclosure to partners. In the second column, we present the odds ratios as adjusted for country of recruitment. In this model, where the effect of the country of recruitment is accounted for, we observe that only membership to support groups and individual characteristics such as age and gender remain associated with disclosure. The third and final column presents the results of the models, including the 4 determinants, that is age, gender, membership to support groups, and country of recruitment. And in this model, we observed that the main drivers of disclosure to partners were country of recruitment and membership to support groups, independently of age and gender. In the analysis of the narrative of our in-depth interviews showed that the reasons for disclosing to partners vary. In some cases, HIV-positive partners feel the need to disclose to protect their partner. In other cases, healthcare needs drive the disclosure process, while others emphasize the good quality of their relationships, showing that trust and motivation to adopt prevention behaviors are related to disclosure. Confidentiality was also considered crucial, and fear of enacted stigma remains an important reason for non-disclosure in the qualitative analysis. For those participants that had disclosed, they reported a variety of consequences. In particular, we found that the acceptance of a partner's HIV status is a process of gradually coming to terms with the results. The initial reaction was often one of shock and disbelief, but most partners actually grew more supportive over time. In conclusion, people living with HIV disclose their status to people within their support network. However, the disclosure within partnership is less common. We found that there is a relationship between stigma and disclosure to partners, but this association is dependent on the setting. It was reported in the interviews that the fear of enacted stigma remains an important barrier to disclosure to partners. Finally, we also found that membership to a support group was associated with non-disclosure to partners. However, this was a cross-sectional survey, and we cannot really state the directionality of this association. It might be that people reluctant to disclose actually to their partners tend to join support groups, or it can be also that the members of the support groups are satisfied with this space for discussion and do not feel the need to disclose to partners. But in any case, it appears that support groups play a key role and should be fully engaged and integrated in HIV prevention programs. They provide a safe space for discussion of, among other things, the benefits of early disclosure, but also the benefits of early initiation of HIV treatment in serodiscordant couples. This project was funded by an NIH grant, and I want to acknowledge all my co-authors, and in particular the participants and the clinic staff of the MATCH study. Thank you.
Thank you, Gabriela, for a very interesting and thoughtful presentation. So at this point, we can take a few questions. It looks like it was crystal clear. Thank you so much.
Thank you.
So we're moving on to our next presenter, Dr. Zegaziab Bezabe from Ethiopia, who has already been introduced, but for those of you who joined us later, I would like to mention that he is working in, he's at Addis Ababa University. He received his Master of Science degree in demography from Addis Ababa University in 2003, and has worked in various organizations, including WFP as a research and M&E officer, UNAIDS and UNAIDS. He most recently has worked as principal investigator for a national level study on stigma. Please go ahead.
Thank you. The issue that I am going to present is the specific aspect of stigma, which is internal stigma among the HIV positive adult population in Ethiopia. This study is part of the Ethiopian Stigma and Discrimination Index study, which was conducted in 2010 and 11. Internal stigma, which is also referred to as felt stigma or self-stigmatization, is used to describe the way a person living with HIV feels about himself or herself, and specifically if he or she feels a sense of shame about being HIV positive. This study is part of the PLHIV Stigma Index research initiative to fill the gap in the global and the national understanding of stigma and discrimination in connection to the HIV and AIDS. The index was developed by the partnership of GNP Plus and ICW, UNAIDS, and IPPF. And the study was implemented by NIP Plus, which is the network of networks of HIV positives in Ethiopia. The methodology that we used in the designing of this study or in the Ethiopian Stigma and Index Survey is a nationally representative multi-stage cluster sampling method. The survey team prepared the list of PLHIV in the selected districts in consultation with health facilities, ART clinic or PMCT clinics, PLHIV associations, NGOs or CBOs working on HIV, home-based care providers, case managers, case workers, PLHIV support groups, health extension workers, and at the end of the day, we were able to successfully interview 3,360 PLHIV all over the country using the standard questionnaire developed by GNP Plus, ICW, UNAIDS, and IPPF. All the data collectors were PLHIV or HIV positive. In addition to the quantitative survey, there was also a qualitative data collection, which include 30 focus group discussions were carried out with various subgroups, including rural and urban residents, male and female PLHIV from different parts of the country. The ethical considerations that we observed during the study or during the survey include all persons involved in the study had signed an agreement to keep the confidentiality of personal information they came across in the course of the data collection. Before the enumerators or the data collectors contacted the selected PLHIV, service providers who are well aware of the HIV status of the person to be interviewed approached the selected PLHIV and reviewed the informed consent form. Then upon the agreement of the PLHIV, the data collector will proceed to interview the PLHIV. The interviewers used an information sheet and informed consent form with each interviewee, and rather than putting the name of the PLHIV to be interviewed on the questionnaire, we used unique identifying code, and we also have secured clearance from the Ethiopian Health and Nutrition Research Institute. Regarding the level of internal stigma, as you can see from the figure here, this figure presents the proportion of PLHIV who disclosed that the nature of various feelings as a consequence of self-stigma they harbor for being HIV positive. These feelings include suicidal feeling of being requiring or feeling of being punished, feeling of having low stigma, blaming others, blaming oneself, and blaming guilty and feeling ashamed. As you can see from the graphs, feeling of every 1 in 5 of PLHIV in Ethiopia have suicidal feeling because of the internal stigma they harbor. nearly half of the PLHIV in the country have also low self-esteem and blaming themselves. And nearly half of them also feel guilty, and nearly half of them also feel ashamed of being HIV positive. When we see the gender dimension, suicidal feeling of oneself should be punished, and having low esteem and blaming others is higher among the females, while in terms of blaming oneself and feeling guilty, and the males are slightly higher than the females. From the qualitative data, just let me show you, let me present you some quotes. I got tested for a third time in the hospital, and finally I admitted that the virus is in my blood. Hence, I decided to commit suicide in the absence of my wife. But I saw my child crying and I started to cool down. The other woman living with HIV also disclosed that I know a husband and wife living in our locality. The husband is HIV positive and the wife is HIV negative. They have 4 children. She said to him that they can live together and raise their children, but he didn't accept the offer. He was caught by the shackles of self-stigmatization, and I had to counsel him several times so that he can correct his behavior. Another woman living with HIV also told us, from now onwards, I do not have the hope of getting married and giving birth. These are some of the quotes that display the situation of internal stigma among the PLHIV. The other aspect of internal stigma is withdrawing from abandoning aspiration of or life goals is also an important and measurable manifestation of internal stigma. During the survey, respondents were asked if they have foregone various family and social activities or opportunities related to career and education, health services in the last 12 months before the survey in connection with their HIV positive status. As you can see from the figure, more than half of the PLHIV have decided not to have children or more children. Some 40% of the PLHIV decided not to have sex, and significant proportion of PLHIV decided not to get married, and nearly a quarter of them isolated themselves from family and friends. And 1 in 5 of the PLHIV also have chosen not to attend social gatherings. What this shows is significant proportion of the PLHIV are withdrawing from the social and communal activities, and they also withdraw themselves from taking services like health and education because of their feeling about their being HIV positive. The last aspect that we are going to see regarding internal stigma is some fear or incidents that the respondents had fearful anticipation of facing in the last 12 months. Nearly 3/4 of the PLHIV were had a fearing of being gossiped about. Nearly half of them also being fear of being verbally insulted, harassed, and or threatened, being physically harassed and or threatened, and being physically assaulted. When you compare the level of their fear compared to the actual or the enacted stigma, their fear or their internal their fear because of their self-stigmatization is far higher than the enacted stigma or the actual stigma. To conclude, the magnitude of internal stigma is far higher than enacted stigma and was noted to be a pressing problem among PLHIV in Ethiopia. Significantly higher proportion of female PLHIV compared to their male counterparts are noted to have taken such measures as deciding not to have children, not to have sex, not to get married, isolate themselves from their family and or friends as a result of their HIV positive status. The prevailing level of internal stigma has deterred significant proportion of PLHIV from active participation in socio-economic activities of the community out of fear of having their status revealed or being discriminated against because of their HIV positive status. And the prevailing level of internal stigma has affected significant proportion of PLHIV in Ethiopia to low self-esteem, a sense of worthlessness, and depression, self-deprivation of access to services and opportunities. And generally we recommend, in order to address the problem, peer-to-peer support groups, skill building, network building, counseling, training should be given attention. Thank you.
Can you hear me now? Okay. So thank you very much for this very interesting and informative presentation. And we're now ready to take some questions. I see we have someone at mic 4.
Do you have any data of the mode of transmission and how that might change the feelings of internal stigma?
No, we did not have that. We didn't collect that type of data.
Mic number 2.
Yeah, it's very interesting presentation and the findings are also interesting. But how this data is useful for the prevention and the prevention part of the aspect of the HIV/AIDS, as well as how it is useful for the health workers and the caregivers, particularly the caregivers. I studied another study of the caregivers. If we see almost half of the caregivers of this population at the family level, they are the spouses. And declaration in Gomez study shows that declaration is a problem for the spousal and the partners. How this information is going to be really useful at the prevention, at the for the health workers also.
Okay. The study covered only the PLHIV, or the study subjects were only PLHIV. We were not able to interview the other groups like health workers or volunteers or this type of categories. But in the study, the PLHIV were asked if their feeling towards the volunteers and health workers. And the perception that we found out in the study is that they have accepting attitudes towards health workers than any other group, like religious leaders or teachers or other government officials. So the PLHIV have much more positive attitude towards health workers and other social workers.
Someone else at mic 4.
Thanks very much for your presentation, Travis Lim from Johns Hopkins. You mentioned that because of internalized stigma, there were several people who reported, PLHIV, who reported that they stated that they made the decision not to get pregnant or not to get married and so on. And often we think of those choices as joint choices. So I was wondering how you distinguish between internalized stigma versus, for example, stigma from their partner or from elsewhere that affected that decision.
During the study, we interviewed the PLHIV whether what significant decision have they made during their life or after they realize that they are HIV positive, and significant number of male and female PLHIV have disclosed that they do not, they have decided to not to have more children and not to get married since because of their feeling about themselves because of their HIV status. So these attitudes are developed not because of other factors, but only because of the fact that they are HIV positive.
We will take 2 more questions. First mic number 1, then mic number 3. Please go ahead.
Yes, thank you for your presentation. You have presented differences between gender, male and female, regarding some important decisions, especially about women. Do you have these persons or women have access to treatment or medication, specifically those pregnant women? Thank you.
Okay, some 86% of the interviewed people were on ART while the study was being undertaken, and among the women who were interviewed or who had been pregnant before some 12 months before the study, almost 3/4 of them had been on PMTCT service. So even though they are accessing this type of treatment services, it didn't prevent them from internalizing or stigmatizing themselves.
Okay, thank you. Mic number 3.
Thanks very much. Gary Breff, Terence Higgins Trust. I was just wondering, given the fact that within those choices that were being made, it was within the last 12 months, what was the average length of diagnosis for the people within the study? Since often people tend to have those feelings of not being able to have sex, not being able to engage with life issues very early on in diagnosis, but that often subsides over time, especially with getting to to grips with diagnosis. So what was the length of diagnosis on average for the study population?
The length of diagnosis on average? How long had time had passed since people first found out that they were HIV positive?
I don't remember the data, but we have collected the data on this, but for the time being, I don't have the data ready on my hand.
Thank you.
Okay, thank you.
It now gives me pleasure. Oops, sorry. I would like to introduce our last speaker of today, Dr. Deepa Rao from University of Washington, Seattle. She's a clinical psychologist and research assistant professor, and her professional interests are in designing effective interventions to improve mental health and reduce stigma for vulnerable populations worldwide. She conducts work in the United States and in South India, particularly with women. She also co-directs the program on global mental health at the University of Washington. Thank you.
Hello, thank you for having me here. And I also wanted to say I'm honored to be here, honored to be speaking in the same room as the AIDS quilt. It's quite moving to see it. So I thought I would start by grounding my work a bit in a conceptual model. And I know we've heard a lot about definitions of stigma and whatnot, but I wanted to highlight that we know that stigma originates from culture, particularly social norms, power structures, shared beliefs about the body, health, and illness. And those take the form of public and institutional stigmas that ultimately impact the individual. And from my survey of the literature, many stigma reduction programs tend to kind of stay in this public level. And many studies are grounded in stigma reduction among healthcare workers. There's very little that we have, I guess, evidence as to what coping skills work to help a person living with HIV combat or cope with the stigma that they face. So this work and this line of work that I'll describe to you is grounded at this individual level. And what we've tried to do is take a look at a bit at intersectionality and try to look at ways of reducing stigma in the context of other marginalized statuses that can impact the person living with HIV. We do know that internalized stigma has an impact on medication adherence. There are many research studies these days that make that connection. And we suspect also that internalized stigma impacts treatment utilization and poor health outcomes. So how can we reduce stigma? We've heard a bit in the presentations here, and we know from the literature that at the societal level, there are studies that show that institutional stigmas, if they're removed, we can reduce stigma in the community. We can use microfinance programs to promote economic empowerment and empower individuals living with HIV. We can use community organizing to empower and reduce stigma. What we know less about are the effectiveness of individual level techniques. We know that there are techniques out there. What we don't know is whether or not they work. And so there are educational tools that we can use. There are coping skills out there that we can teach. And we know fundamentally that contact between and among people living with HIV can help to reduce stigma. So social support is a nice tool that we can use to reduce stigma. Many years ago now, it was AIDS 2006 in Toronto, Laura Nyblade was presenting for the first time, I believe, the HIV Stigma Toolkit. And this is a toolkit that actually contains some of those elements that I mentioned before. Education had the potential to promote contact between individuals and help to reduce internalized stigma. This is a toolkit that was originally developed in Zambia, and since then, facilitators have been trained globally and it's used worldwide. What we did was we took the 40+ exercises from the toolkit and held some focus groups with African American women living with HIV, both in Chicago and Seattle. And we asked them for their feedback and asked them to help us repackage the materials into an intervention that was relevant for them. We also developed trigger videos from the toolkit, and the trigger videos were meant mainly to model proactive behaviors and trigger discussion around how to handle stigmatizing situations. We called the repackaged intervention the Unity Workshop, and I'll mention why we called it the Unity Workshop. Why do I keep wanting to call it University Workshop? I don't know, but Unity Workshop. This is basically an 8-hour workshop that we piloted to be held across 2 afternoons. It was peer facilitated. Basically, we have a wonderful African American woman living with HIV. She's an activist and a role model. And she was trained to basically facilitate this group workshop. We also, we recruited participants, and ultimately 24 African American women living with HIV from the Seattle area participated. These women were living with HIV from anywhere between 3 months to 25 years. And at the start of these workshops, I'll give you a few examples of the content of the workshops. We started out by discussing group expectations. So this was a very participatory workshop. We didn't set out ground rules. We asked them what their expectations were for the workshops. We asked them to talk a bit about their experiences around stigma, what did stigma mean to them, to kind of, I guess, help in promoting social support within the group. We also had some exercises where we asked them to share methods of coping. So many of them shared their methods of coping with stigma, like prayer or speaking with family, and they were able to share reasons and discuss with their peers in the group what worked and why it worked for them. We also gave them time to role play ways to navigate stigmatizing situations. We had one exercise that was in the original HIV stigma toolkit where the women formed a web of string. And the women named this web, and they called it, they said it represented peace, unity, and togetherness. And which is why we call the workshop the Unity Workshop, because of their name for this web and also what the workshop symbolized for them. I'm going to show you a trigger video now so you can kind of get a sample of one of 4 trigger videos that we used in the intervention.
I come from a family with 6 kids. I have an older sister, Danielle, and then we have 4 brothers. Or we did have 4 brothers. My brother, Jimmy, died 3 years ago. My sister, Danielle, and I are really close. She's always looked out for me. Maybe it's because it was always us against the boys. Anyway, even though we don't live too close together and she's busy with her son, we still talk on the phone all the time. And we try to get together and have coffee or go for a walk at least once a month.
So, Danielle, I wanted to get together for a reason today. There's something I have to tell you.
What is it? Alex, you can tell me anything. That's what sisters are for.
Well, this week,
What is it, sweetie?
I tested positive for HIV, Danny. I have HIV.
Oh. It's okay. Oh, it's okay. We'll get through it together.
I need you to keep it a secret. Do you want to tell Mom?
No, of course not. I'm here for you, Alex. Trey, go ahead and run up to the park. Oh, boy. Oh, I better take this. It might be about the car we're selling. Keep an eye on Trey.
I'm coming to get you. Here I come.
Yeah. Uh-huh.
Go fast. Do we go faster? Yeah? You sure? Fast? Okay. Whoa!
Great. Then we'll see you later. All right. Thank you. Bye-bye. Trey, I need to talk to Aunt Alex for a minute. Alex.
Are you gonna buy the car?
Alex, you are too sick to be running around like that. You need to rest. Take it easy, girl. Go sit down. Let me push Trey on the swings.
Yeah, you're probably right.
Great. Well, thank you for calling, and we'll talk to you soon. All right. Bye-bye. Trey, I need to talk to Aunt Alex for a minute. Alex?
What is it? Are they gonna buy the car?
Alex, you are too sick to be running around like this. You need to take it easy. Take it easy, girl. Go sit down and let me push Trey on the swing.
Danielle, I'm fine, okay? Trey and I were having fun. Can you just let us have our fun, not boss me around for once?
What did I say? Yes, I'll look forward to your call. Thank you. Bye-bye. Trey, I need to talk to Aunt Alex for a minute. Alex. Getting out by the car? Alex, you are too sick to be running around like that. You need to take it easy. Get some rest, girl. Go sit down and let me push Trey on the swings.
Danielle, I want to thank you for your concern, but it's not necessary. You've always looked out for me, and I love you for it, but I'm fine, really. I'm on meds, I'm healthy, I feel good. There's no need for me to slow down. Come on, let's go push Trey together. Come on, come on.
Okay, so you can see from the video that basically this particular video had 3 separate endings, and it was able to promote discussion on different ways of handling a potentially stigmatizing situation, so a passive way, an aggressive way, and an assertive way. And the women were able to kind of bounce around the pros and cons of each type of manner of handling a situation. The other thing I wanted to mention was, so we have 4 trigger videos, and after each one, during our pilot study, the women really couldn't contain themselves after seeing these videos. They promoted so much discussion that everybody wanted to speak at once. So it was an exciting aspect of the intervention for the women. We did do also a kind of classic pilot study and look at not only feasibility, but just preliminary effectiveness. And we used a pre-test, post-test design and paired t-tests to analyze the data. Our primary outcome was the stigma scale for chronic illness, which is a 14-item scale that we adapted for African Americans living with HIV, and we validated with this population. If you're interested in more about the scale, I have the paper that's under review with me, and we can take a look at some of the items. But basically, the results said that after preceding to 1 day after the intervention, there was a 5-point decrease in stigma scores. And then 1 week later, there was a 4-point decrease in stigma scores. And so basically, stigma was reduced after participation in this intervention. The results were not significant, but we did see a trend. And the other thing to notice here is that there's a slight creeping up of levels of stigma after about a week. So limitations of this study were primarily there was no control group, and there was not significance, although we did find a trend. Our hope and thought is that we only had 24 participants, and that if we increase the sample size, that we might see some statistical significance. We also potentially foresaw the need for a booster session, and that the stigma levels started to increase a bit, and so we foresaw the need for that. And our next step is basically a full-scale randomized clinical trial, and we hope to conduct this trial in 2 different cities, in Chicago and Birmingham in the future. So I'd like to thank my supporters and funders, and first and foremost our participants, and Tom Furtwängler, who produced the videos, James and Margaret Longley, who did camera and sound for the videos, and Yamile Molina, who helped script some of the videos. Some of the content came from focus group discussions and some from the ICRW HIV Stigma Toolkit. And I'd also like to thank the NIMH, who funds my Career Development Award, to promote this work. So thank you.
Thank you, Deepa, for this interesting presentation. And now we will open the floor for some questions. Okay, at mic 4.
Sorry. I'm wondering if there have been any studies that have done research in regards to people outside of urban areas.
I believe there is some work going on stigma reduction in the Vermont rural areas. It's just coming out now, I believe. I think there was a paper out very recently. Yeah, I haven't mentioned it here, but there is work in rural areas on stigma and stigma reduction.
Okay, mic 3.
Hi, I apologize if you already mentioned this, but are those videos available for use by other organizations? And if so, where would we find them?
Thank you, good question. So I guess due to my own error, I had promised to give them to the Stigma Action Network to put on their website, and I think I failed to do so, have I not, Anne? They are on YouTube, but it's hard to search for them, which is why I'd like to do that. I have 3 copies of the videos on DVD right now, though I'm anticipating that demand might be more than 3 copies. So I would say look on the Stigma Action Network in, a few months, Anne, and they might be there, or it might take longer. I think it depends on me. You can also, my email was up there. It's just my name at uw.edu, and you can email me and I can send you the links to the videos. Okay? We're also hoping to put, by the way, the workshop materials on their website as well, not just the videos, because the videos are embedded within workshop materials, the manual.
Okay, over to Mike 2. Please go ahead.
My question has to do with the group participants. Were any of the women lesbian, bisexual, or transgender that participated? And the second part is, did any of those trigger videos address that diversity? Or did you assume that most women were not?
I'm trying to think if we collected that data, and I don't think we did. However, the 8 hours of the workshop were open to discussion on any topic. So women did talk about race. They did talk about being women within African American communities and that marginalized status that they had, and they were open to talk about other things. Some women did talk about drug use, but I really am unsure whether sexual orientation, I don't think it came up in the workshops. I sat through both versions of the workshop, but the discussions had a lot of open time for people to bring up any experiences that they had that they wanted to discuss, or any status or condition anything they wanted to bring up that they felt stigmatized by.
The reason I asked the question was because in Toronto, we work with a lot. I work with Carmen as well, with African, Caribbean, Black, Canadian women. And in the study that we did ask about queer women, Black queer women living with HIV. And it was resounding in that, both the focus group and follow-up, that queer women felt completely silenced and that they had a challenge with any of the supports that were offered because they didn't feel supported or have the courage to bring that up, and when they did, they were shut down. That's one of the reasons I asked, so that if there was a trigger video or material, I would more than happy to share it.
Yeah, the other thing I wanted to mention was that our peer facilitator did openly disclose that she has a female partner. They were, that was part of the group expectations is, respecting, others in your group and that sort of thing, and feeling open to talk about anything. But it's really nice to hear that you have some materials on this as well.
So we'll talk. Thank you.
Yeah.
Okay, Mike 3, please.
Hi, Lizzie Schmidt from Philadelphia. Can you tell us if the peer facilitator had training, and if so, can you describe it?
So there were 3 people in the room. I was there just as an observer. We had a social worker in the room, and then our peer who was there mainly to help with data collection. But the peer facilitator was trained. We had manualized the intervention, and we trained her in how to, we kind of ran through the exercises, and she also brought in her thoughts, and group expectations was actually her idea rather than laying down ground rules. So she was experienced in peer group facilitation. She runs a weekly support group, and she knew that, procedures to follow in case of, highly distressing situations and that sort of thing. I'm a clinical psychologist by training, so I was there on hand in case there were any issues that came up.
Okay, now the last question for the evening, that's Mike 4.
Hi, this is Laura Nibley. This is less of a question than a comment, just to say thank you for your work and for using the Stigma Toolkit. I just wanted to make a slight correction, and that is that it was developed in Ethiopia, Tanzania, and Zambia, as well as eventually in Vietnam, just to give those countries credit for that. And just to say that the Stigma Reduction Toolkit is available on the Stigma Action Network. I don't know if you already talked about that's availability. And we also have similar tools that work on stigma towards sex workers and stigma toward men who have sex with men and stigma towards drug users. As we've been talking about the intersections here, just want to say those tools are available. And then I want to make one last plug, since you're all here late for a stigma reduction section, is that this evening we have the Robert Carr Memorial Lecture. Robert Carr was an activist in the Caribbean who worked tirelessly to reduce stigma and discrimination. And we're having the first memorial lecture tonight. It's in the Global Village, and Stephen Lewis will be speaking on stigma. So I think you'll all want to go. I have flyers if you want to pick them up on the way out. It's in the Global Village. It's at 6:30. Thanks.
Thank you, Laura.
Thank you. Okay, this will be the last question at mic 3. Please go ahead.
Good evening, and thank you for your presentations. This is not a question directly to the presenter, but just earlier before, a gentleman was mentioning about faith-based communities, and I was just wondering how, as physicians, as social workers, you can deal with MSMs, lesbians, etc., where you have the community, a Christian community, for example, that are totally against these types of behaviors in order to reduce the stigma and reduction, because we're trying to help everyone. So it can be a little difficult, so I'm just asking if you can shed some light on that. And
I don't think this is a question just for me, but the one comment I could make is I'm a trainee of Patrick Horrigan in Chicago, and he has recently said in a paper of his that contact is fundamental. So promoting contact, having open dialogue and discussion is fundamental in reducing stigma of any type.
Okay, thank you, Deepa, for this very interesting presentation. With that, we come to the end of this session, and would like to give a warm applause to all of them. We thank all the 5 presenters, and we thank the audience. We thank those who asked questions and made this a very lively discussion session. And we would like to, I'd also like to thank Maria, my co-chair. And we understand that in the 4th decade of the epidemic, stigma continues to be a challenge and continues to make us think that we need to invest more energy, more research, and perhaps more funds into understanding stigma as a phenomenon, and to see how we can address stigma as a real barrier to accessing services, utilizing services. Thank you all very much.